Hello, my name is Dr. Ramos. I'm the head of the arrhythmias unit in University Hospital Clínico Lozano Blesa of Zaragoza, Spain. Recently, we have published a paper in Frontier Cardiovascular Medicines regarding to CTI ablation with low-fluoro and arrhythmia. The aims of this study were two. One was to assess if a low-fluoro approach with arrhythmia in a CTI ablation was feasible, and the other one was to assess if contact force and local impedance drop with the direct sense technology with a stable point catheter are useful predictors of a successful CTI ablation. We divided the CTI in 3 segments, and we look at each application and we see if the contact force and the local impedance drop can predict a successful application. A local impedance drop above 30 ohms or above at 20% in the relative value of local impedance drop were the limits to say that the application is a good application. So our findings were that the contact force does not predict itself a successful application, but the local impedance drop does predict successful applications. Contact force is useful to see that you're going to have a good local impedance drop, and the local impedance drop is the parameter that you have to use with a stable point catheter in the CTI ablation to have a successful ablation with no gaps. Local impedance is a very useful marker because it's the unique parameter that has proven to be useful in the CTI ablations, because contact force itself does not predict a good ablation. The local impedance, about 30 ohms of local impedance drop, or about 20% in the relative values of local impedance drop, does predict the successful ablation. So you are getting lower times of the total procedure, and also lower RF times. If I have to give an advice of local impedance, is that you have to be aware that when you have applied what you have already burned, that tissue, it's changing its local impedance from the basal one. You have a lower local impedance, 20 or 30 ohms lower. So if you perform like 2 very close tags, you don't expect the same local impedance drop than when you have your first application in the CTI ablation. If you have a very large local impedance, I mean above 45, 50 ohms, you have to stop the applications to be safe. When you reach the value, the target, like 30, 35 ohms, you don't have to spend a long time with the RF application. You don't have to spend 30 or 40 seconds. When you reach it, you could stop your applications. A low-fluoro approach is very important, not just because of the patients, that we know that radiation have very important secondary effects, but also for the operators, the EPs. We are going to spend like 30 or 40 years performing ablation, so being exposed to the radiation, it's a risk. Also, wearing the apron, the lead aprons, is affecting our back, and we have cervical illness. The thing to have a navigation system and to get into the lab with any lead apron, you feel more comfortable and you have a more precise view that what you are doing. For instance, in the CTI ablation, when you have a gap, you just have to look where the gap is. If you don't use a navigation system, you don't know where the gap is, so you have to apply very long RF times. It's proven that low-fluoro, minimal-fluoro approach is safe and effective. Also, in some substrates, it could benefit in your results, could be more effective. AVRTs and some accessory pathways, so I think it's a good practice. I think it should be the present practice, and I'm sure it could be the future practice of the EP.